Now we're going to talk about COPD, chronic obstructive pulmonary disease. First, we divide in emphysema, asthma, bronchitis, and bronchiectasis. All of these, what they have in common is that they are obstructive, so we cannot expire all the air that we inhale. So the residual volume, the volume of air that we cannot expire, is increased. We have increased the residual volume. This increases the total lung capacity. The total lung capacity is the sum of all the four volumes. We have a diminished ratio of FEV1 to FVC. This is forced expiratory volume in 1 second divided by forced vital capacity. And this is the diagnosis. The first, when we have suspicion of this, the first thing that we're going to do is the spirometry, and we're going to measure the pulmonary function test. And then the chest X-ray. In the chest X-ray, we will see barrel chest because of the air. We would see first that the person looks, the thorax is like inflated, so they say barrel chest. We could also see more clearly the ribs because of all the air that is inside, so the ribs go out, and we can see them. We can see the ribs, and we have the costodiaphragmatic recesses are non-visible. They are obtunded. We don't see them anymore. So we have loss of the costodiaphragmatic recesses. Alright. Sometimes we use divide in emphysema and chronic bronchitis. In chronic bronchitis, we also say that these are the blue bloaters, and emphysema are the pink puffers. Blue bloaters because they are cyanotic because of the hypoxia, and pink puffers because these are the one that has emphysema, but are not as bad as others could be, and so they don't have hypoxia yet. If they have hypoxia, they would be blue, but they are pink in this mnemonic. Alright, emphysema could be panacinar or centriacinar. More or less, we have other types like distal panacinar, that we don't know the etiology, or irregular, that is because of scarring. But usually we use divide in panacinar and centriacinar. Panacinar is when all the lung is equally damaged, and so we have pan, everything. We have all the lung has the emphysema. This means if these are the airways, all the airways are going to be dilated. In centriacinar, we just have at the end of the terminal bronchioles and respiratory bronchioles, we have the dilation, and then we have the alveoli. But the dilation is in the centriacinar, could be in the terminal bronchioles, in the respiratory bronchioles, and in the alveoli is the damage of losing the elastic fibers. But the dilation, the primary dilation, is centriacinar, don't in the peripheries, in the center. So centriacinar is in smokers because we inhale the smoke and it goes first to the center of the airway and then more distally. So this is the part that is most affected, and so is centriacinar for those who smoke. And panacinar, we see it in deficiency of alpha-1 antitrypsin. This is the the protease that destroys the elastase and other proteolytic enzymes. These proteolytic enzymes, elastase, collagenase, and all these, destroy the collagen and the elastic fibers that are in the lungs. And these are the fibers that permit the recoil, the elastic recoil of the lung. If we lose them, the lung is more compliant, can expand, and cannot contract, cannot do that collapsing. The alpha-1 antitrypsin prevents these proteolytic enzymes to destroy the collagen and the elastic fibers. But if we have deficiency of these, we don't have this protection, and the macrophages that releases macrophage neutrophils that releases these elastase and proteolytic enzyme destroy them, and we don't have the protective effect. So we have compliant, very compliant lungs and the dilation because we cannot do the expiration. For this, we have accumulation of air and we have the increased residual volume. Panacinar usually is in the lower lobes and centriacinar in the upper lobes. In panacinar, because of alpha-1 antitrypsin deficiency, we also have liver damage because inclusion bodies of the alpha-1 antitrypsin that is modified. We have a mutation in the gene that codifies for alpha-1 antitrypsin, but it is mutated, so we have mutated protein, and that protein accumulates in the endoplasmic reticulum of the liver, and this could lead to liver failure. Alright. The normal allele is PIN. The mutated allele is PIC. We can have heterozygous person or homozygous for PIC or for PINN. Homozygous for this would be the normal person. PIC, PIN, it has a little risk of emphysema if he or she smokes. Usually it's asymptomatic unless he or she smokes. And PIC, homozygous, is almost certainly develops the emphysema. And obviously it's going to be less than 65 years of age, with very young person that has the emphysema and could have little or no smoking history. Alright. In emphysema, we lose the elastic fibers. We have diminished the diffuse lung capacity of CO2, and we have lose the radial traction because we lose the elastic fibers. So when the alveoli expand, they cannot expand the small airways. This is radial traction because usually the alveoli, the walls of the alveoli are tethering the walls of the respiratory bronchioles, but here we are losing the elastic fibers, so we don't have the radial traction. The airway doesn't expand at the expiration, and we cannot get out the air. This when we have pink puffers is because we have usually the same degree of damage to the alveoli and to the vasculature. If we have more damage, let's say to the airway, we will have cyanosis. And this patient also can have hypoxemia because of the destroying of the vessels, of the alveoli vessels. Alright. Now the asthma. Asthma is part of the atopic diseases. We have a lot of IgE. It is an autoimmune disease. We have more CD4 positive T cells that are responsible for this. This increases secretion of IL-4 that makes that the B lymphocyte goes to somatic hypermutation and increases the IgE secretion. Also secrete IL-5 and eosinophilic tract chemotaxis, so we have recruitment of eosinophils, basophils, and mast cells. The mast cells and the basophils are the one who that mediate the disease because the activation obviously of the T coming from the T lymphocyte, and the eosinophil is here in the disease. We have a lot of eosinophils, but they are like trying to contrarrest the effect of basophils and mast cells. The mast cells release the chemotactic factor for eosinophils, and the eosinophils also has aryl sulfatase and histaminase that are trying to destroy the histamine and everything that basophils and mast cells are producing. Classically, asthma, we would see Kurzman spirals and charcot-laden crystals. Kurzman spirals are desquamative epithelium, and they look something like this. And charcot-laden crystals are something like this. They have like two ends very clearly, and these are eosinophils that are dead and mucus. Asthma is more common in children, but also in adults. We can have exposure asthma that is related to exposure. We can have exacerbation of asthma or asthma drug-induced asthma with NSAIDs or aspirin because we block the cyclooxygenase enzyme. We just have the lipoxygenase that converts the arachidonic acid to leukotrienes, and the leukotrienes produce bronchoconstriction. Alright. Asthma has normal or increased diffusion lung capacity. It's the only one who has it normal or increased. All the others have it diminished. The lesion in asthma is also in the bronchioles, in the small airways. In asthma is in emphysema. The dilation is in the bronchioles, in the bronchioles and in the alveoli. That we must say that the damage is in the alveoli because there is where we are losing the elastic fibers. Chronic bronchitis. In chronic bronchitis, we have the clinical diagnosis is coughing and dyspnea more than 3 months in 2 years, more or equal than 2 years. Productive cough, very productive cough. We have rales or crackles. Crackles means obstruction of airway and mucus secretion. And we have wheezing. Wheezing is the high-pitched polyphonic sounds that means just obstruction of the airways. Also in asthma we have wheezing. So this presents like cyanosis because they have hypoxia. We can have maybe clubbing of the digits. We are going to measure the rate index. This is because these patients have hyperplasia of the goblet cells, the glandular cells that produce mucus. We have, if we take the wall and we measure the ratio of the glands, the space occupied by glands to the wall, this is increased. Normally is less than 40%. If we have more than 50%, it's also diagnostic of chronic bronchitis. Alright, chronic bronchitis is also associated with smoking. Both of these emphysema and chronic bronchitis are associated with smoking. And we have a lot of T lymphocyte, CD8 positive, and some macrophages. But these are CD8 positive. And in what's this? Bronchiectasis. In bronchiectasis, this is chronic inflammation, necrocytic inflammation, could be by infection or decrease in the ability of clear the allergens. This presents with cough, mucoid or mucopurulent or purulent sputum, foul smelling. The most common cause of bronchiectasis in the United States is cystic fibrosis. In other countries is TB. Also, microorganisms that are associated with this are Pseudomonas aeruginosa, Staphylococcus aureus. In patients with cystic fibrosis, also Burgdorferias hepatica. There is a syndrome, Cartagena syndrome, that has the triad of situs inversus, chronic sinopulmonary infections, and infertility. The chronic sinopulmonary infections is because they cannot have this is an effect in cilia. The cilia are part of the columnar epithelium of the lung. They act like to do this, then this, and this, and so they are clearing the airways. These patients cannot clear the airways because they have mutation in the presence of the cilia, so they have chronic pulmonary infections. Also, allergic aspergillosis, allergic chronic allergic aspergillosis is caused by Aspergillus fumigatum, and is usually in patients with asthma or cystic fibrosis, but they produce bronchiectasis and mass that is invading the cavity. This patient can have hypoxia, they can have cyanosis, and they can have hemorrhage. Hemorrhage would be usually is just hemoptysis because they rupture the vessels of the bronchioles because of anastomosis. But if they rupture the high pressure vessels, they can have life-threatening hemorrhage. We have anastomosis, we have dilated tortuous fragile vessels, and also dilated airways. The bronchiectasis is the permanent dilation of the airways, could be like because of necrocytic inflammation, infections, etc. And we have the cyanide ring sign, that is the diameter of the airways is greater than the diameter of the nearby vessels. All these patients of the treatment is bronchodilations, could be sometimes in the exacerbation corticosteroids. That would be more for emphysema than and asthma. We are going to see the specific treatments of asthma and indications in other videos. Here is just the general picture. The exacerbation, the treatment of the exacerbation, the acute exacerbation is usually with the bronchodilation that are beta-2 adrenergic receptor agonist, could be SABA or LABA. Some corticosteroids. We could use non-invasive positive pressure ventilation plus B11 positive airway pressure. If non-invasive positive pressure ventilation fails, then we do intubation, but only then we do intubation. And yeah, we will see how is the patient, and then we could get the intubation, get out of the intubation. Patients with chronic pulmonary chronic obstructive pulmonary disease, obviously the treatment is cessation of smoking. We are going to give the vaccines of strep pneumo. These are PSB23 and PCB13. This is the non-conjugated vaccine, just polysaccharide vaccine, and this is the conjugated vaccine with toxin. This we just give if the patient has less than 68 years of age, and this if is greater or equal to 65 years of age. Also, indications for therapy, long therapy with oxygen supplementation are partial pressure of oxygen in the arteria less than 55% and or 88% of oxygen saturation, or partial pressure of oxygen in the arteria less than 59% and saturation of less than 89%, plus some sign of congestive heart failure or cor pulmonary, right congestive heart failure or cor pulmonary. These patients, obviously, we advise to stop smoking. The acute exacerbation could be dosed. Some animals of viral infections are influenza virus, parainfluenza, and rhinovirus. These are the most common. Also the coronavirus, but this is not as common, well, unless now during this pandemic.